Good morning. There are a huge number of patients who suffer from chronic kidney disease, which means that they now are unable to remove excess fluid and waste products from the body, because that is primarily the function of the kidneys in the human body, apart from, of course, making red blood cells and also controlling blood pressure and making the bones strong. Now, the prevalence of chronic kidney disease is very high. There are about 37 to 40 million people in the United States, and one can presume that there would be at least 100 million people, if not more, in India. There is a paper which was published a few years back in the Indian Journal of Nephrology, and this gave us an estimate of about 800 per million, or about for chronic kidney disease, and about 200 per million for end-stage renal disease, which again means that there are lakhs of people who are suffering from chronic kidney disease. Now, there are some drugs which have been shown to prevent the progression of kidney failure. Chronic kidney disease is also kidney failure, and there are a lot of presentations, but primarily there are three causes for kidney failure. The first one is diabetes. The second one would be blood pressure, high blood pressure, uncontrolled high blood pressure, and third would be kidney disease, that is glomerular disease. Now, three kinds of medicines have been shown to prevent, or rather retard, the progression of loss of kidney function. The first group of drugs are called RAS, and these would be an ACE inhibitor or an angiotensin receptor blocker. The second group of drug is a non-steroid mineralocorticoid receptor antagonist called finerenone. And the third are, of course, the sodium glucose cotransporter 2 inhibitors, or the SGLT2 inhibitors. Now I would be talking about empagliflozin, which is an SGLT2 inhibitor. Empagliflozin initially was used primarily only for diabetes. It is an anti-diabetes drug. But then there was this big study which was published and presented in 2015. And this was the EMPA outcome trial, which was a randomized trial and which included 7,000 patients. These were followed for 3 years. These were patients of diabetes and having high risk for heart disease or stroke, that is advanced diabetes. And we have 7,000 patients. Half of them were randomized to empagliflozin, either 10 milligrams or 25 milligrams once a day, and half of them had standard treatment with a placebo. Now, these were all patients with diabetes. What was found at the end of 3 years was that there was a significant reduction in cardiovascular deaths by 38%. Heart failure was reduced by 35%, and all-cause death, that means deaths because of all causes, was reduced by 32%. Now, these are big numbers. I will repeat that cardiovascular mortality was reduced by 38%, heart failure was reduced by 35%, and all-cause mortality was reduced by 32%. However, there was no reduction in myocardial infarction or stroke, so it became apparent that this medicine, that is empagliflozin, did not prevent the progression or the complications of atherosclerosis, that is arteries that are blocked. However, somehow it did reduce hospitalization for heart failure and cardiovascular mortality. Now remember, this study was done only in patients with diabetes, with advanced diabetes. In 2019, we came with another study, and this was the Emperor Reduced trial. Now, because in the first study, we found that empagliflozin prevented hospital admissions for heart failure. This study took about 3,700 patients with heart failure with reduced ejection fraction, that is an ejection fraction of less than 40%. In fact, the mean ejection fraction here was 27%, and these were randomized once again to standard therapy or to empagliflozin. The dose used was 10 milligrams once a day. Now here it is very important to keep in mind that in this study, that is the EMPEROR reduced trial, 50% were patients without diabetes. So now we were using this medicine, which was originally used for diabetes. We are using this medicine for patients with heart failure and also patients with or without diabetes. What was found was that the composite endpoint of cardiovascular mortality or hospital admissions for heart failure was reduced by almost 30%. And again, this was significant. Also, there was a reduction in hospital admissions by almost 25%. Now, there was no significant reduction in mortality, but the message was clear that if there is a patient with heart failure, with severe heart failure, that is with reduced ejection fraction of an ejection fraction of less than 30%, and the NT-proBNP in this study was almost as high as 1,900 picograms per mil, which is pretty high. These were patients with very severe heart failure, and in a follow-up of 1.6 years, there was a significant reduction in hospital admissions and the composite primary endpoint of hospital admissions for heart failure or cardiovascular death. Then we had another study called the EMPEROR preserved heart failure trial. Here, the ejection fraction was about 54% on an average. These were patients with heart failure with a preserved ejection fraction, that is heart failure with PEF, HFpEF. And the number of patients were almost 6,000. These were followed for about 2.6 years. Half of them were randomized to empagliflozin at a dose of 10 milligrams once a day, and the other half received standard therapy and of course a placebo. And what was found again was that there was a significant reduction in the composite endpoint of cardiovascular mortality or heart failure admissions for patients. And once again, it was clear that empagliflozin also worked in patients with preserved ejection fraction. In this study, the NT-proBNP levels were around 900 to 1,000 picograms per mil. But what came out very clearly was whether the patient had diabetes or did not have diabetes, there was once again a reduction in the composite endpoint of hospital admissions for heart failure or cardiovascular mortality. Mortality when taken alone was not reduced significantly, but there was a definite trend towards a reduction in mortality. So I will summarize at this point. We have one medicine, which is an SGLT2 inhibitor. It is called empagliflozin. This is freely available in India. I think the cost is about 15 rupees per day. That is, one tablet costs 15 rupees, a tablet of 10 milligrams. This would mean that in England, this would cost about 15 pence, and in the United States, about 20 cents. So that is a reasonably cheap drug, and we find that it is quite effective in diabetics to prevent the onset of heart failure. And if a person has heart failure, it prevents the hospital admissions, readmissions, or cardiovascular mortality. One thing that was seen in these trials was that somehow this drug was also, although it was working in the kidneys, it was preventing or reducing the decline in the kidney disease. That is, progression of kidney failure was reduced by this drug. The fall in the GFR was much less when empagliflozin was used. And now finally we have a very large study, which once again is a randomized study, and this has 6,600 patients. This was presented 3 days back and was simultaneously published in the New England Journal of Medicine. This is called the EMPA kidney disease. Yes, this is the EMPA kidney disease trial. 6,600 patients with chronic kidney disease. These once again are diabetics and non-diabetics. The average age would be around 63 or 64 years. About 70% were male. And the average, the median estimated GFR, that is the glomerular filtration rate, is about 37 mils per minute. Now, the GFR, or the glomerular filtration rate, is the parameter by which one objectively assesses kidney function. And therefore, if this is reduced, that means the person is having chronic kidney disease. The normal level should be more than 90 ml per minute per 1.73 meter square. However, I will make it simple. If the GFR is more than 90 per mil, if it is more than 90 mil, then the kidney is fine. If it is less than 90 mil, then the kidney is slightly compromised. And if it is reduced dramatically, very much, that is below 30 or even below 20, then the person has very severe chronic kidney disease and the person is now heading for dialysis. Now, as I've already mentioned, if a person has chronic kidney disease, that is, there is a compromised GFR, which also can be reflected by an increased blood creatinine value, the effort by the treating physician is to provide such a medicine that will now slow the progression of the loss of function, loss of kidney function. And as I've said, there is a class of medicine called RAS, that is the renin-angiotensin-aldosterone inhibitors. And these would be an ACE inhibitor or an angiotensin receptor blocker. And then we also have the non-steroidal mineralocorticoid receptor antagonist, which is finerenone. And then, of course, we have the SGLT2 inhibitor, which could be Empagliflozin and also dapagliflozin. Both are freely available in India. Now, back to the study, back to the EMPA kidney study. We have 6,600 patients of chronic kidney disease, which were defined as having an estimated GFR of below 45 from 20 to 45 mil. Or if it was more than 45 and between 45 or 90, then they took a ratio of urinary albumin to creatinine, which had to be at least 200. The normal urine albumin creatinine ratio should be less than 30. So here they were taking patients who had some form of albuminuria, that is, they were leaking proteins in their urine, which again indicates that there is chronic kidney disease. So we have, I repeat, 6,600 patients with chronic kidney disease, and this is defined as an estimated GFR between 20 and 45 mil, or if the estimated GFR is between 45 and 90 mil, then the urine albumin creatinine ratio has to be at least 200 or more. Now, these patients were taken. In this study, 30% of these people had chronic kidney disease because of diabetes. 25% had this chronic kidney disease because of glomerular disease, and about 21% of the patients had chronic kidney disease because of hypertension. And the follow-up was for about 2 years, and the endpoint was a combination of deterioration in kidney function or cardiovascular mortality. This was reduced by as much as 28%. So there was a significant reduction in the slowing of kidney disease or kidney function. There was also a reduction of 14% in hospital admissions for heart failure. So in these patients who did not have heart failure to begin with, but just had chronic kidney disease, there were some people with diabetes, there were patients without diabetes. When one used empagliflozin at a dose of 10 milligrams once a day, there was a significant reduction in the progression of kidney deterioration. Or rather, in simple English, there was a significant slowing of kidney disease, which is highly desirable. How did they define patients of people, or how did they define slowing of kidney disease? The definition was that either the person had a drop of the estimated GFR by 40%, or the person had a fall, an absolute fall of 10 ml per minute of the estimated GFR, or the patient then went down or needed dialysis, or the patient died because of kidney disease. So remember, all these factors which reflect a deterioration in kidney function were arrested, were reduced significantly to the tune of 20% when empagliflozin was used in this trial. Now again, there was the advantage or the effectiveness of empagliflozin was seen across the board. This was seen both in men and women, because this is an international study. It was seen in all ethnicities. The average estimated GFR to begin with was about 37 mils, and also the effect was seen both in diabetics and in non-diabetics. So what is the take-home message? The take-home message is that we have this drug which is called empagliflozin, and this is an SGLT2 inhibitor. This is available in all cities in India. The cost is about 15 rupees, which is not very much. So if there is a diabetic, it would be a good idea. A diabetes that is type 2 diabetes. I'm not talking about type 1 diabetes, I'm talking about type 2 diabetes. In a patient of diabetes type 2, it would be an excellent idea to add empagliflozin 10 milligrams once a day to the regimen, because this would prevent the development of the requirement for hospital admission and even cardiovascular mortality. If the person is having heart failure, whether it is heart failure with a reduced ejection fraction or heart failure with a preserved ejection fraction, once again, if 10 milligrams of empagliflozin is added to the regimen, there is a significant reduction in the composite endpoint of cardiovascular mortality or heart failure admission in a hospital. And now coming to the last bit, if there is a patient of chronic kidney disease, and I would like to remind you that such patients are in the lakhs, in the millions in India. These people who have a estimated GFR of less than 90 mils, once again, it would be a good idea, it would be prudent to add empagliflozin 10 milligrams once a day to prevent the deterioration in kidney function, to slow down the deterioration in kidney function. This is reduced significantly with empagliflozin, and also there is the advantage of preventing heart failure, hospital admissions, which was seen initially about 7 years back in the EMPA outcome trial, where patients of diabetes, when given empagliflozin, there was a reduction in hospital admissions and hospital mortality and cardiovascular mortality. So to summarize, a patient with chronic kidney disease, it would be advisable to give such a patient, whether the patient is a man or a woman, whether the patient is suffering from diabetes or not, it would be a good idea to give empagliflozin 10 milligrams once a day to prevent or reduce the loss of kidney function. Thank you very much.